Any investment needs a mechanism on the ground through which that investment can actually get to the ground. And obviously, it also provides space for government itself to make the initial investment, because you can't always be asking when you're not making the investment yourself. And so that's why we have taken the commitments that governments have made at the global level. We've had agreement at SADC level, and now we are at country level supporting the countries to first formulate those needed policies. They are cross-cutting, they are complex, they are difficult to understand, and then cost those policies, and then of course start the pilot part, like I say, to demonstrate impact on health system strengthening, health outcomes, improvement, the socio-economics of what we will invest in. Now, if we zero in, for example, in the Zambian scenario, the policy that we are revising now gives us room to expand already what Professor Roma Chilengi alluded to. The social health insurance for us has been a game changer in terms of service delivery. As you heard, it's a government mechanism. It started with the public sector, and obviously private sector is coming on, and even the individuals are coming on. But obviously it doesn't cover everybody still. We still have gaps in the social health insurance that need to be closed, that we hope investors or colleagues and partners here can be interested in, because the government has already taken the bigger chunk of all this. And then, of course, we want this service to be provided on, as close to the people as possible. And of course, maternal child health becomes the priority. It's the entry point. It's the best investment that we can actually make that will touch not only the individual, but it's the family. It's the community that will be, impacted by this. Now, we still need to create the service, have investments in the delivery mechanisms, because we do have social health insurance everywhere, but then we don't have the facility to actually provide the service. I can pick a rural district. It has a district hospital, but it may not have the equipment. It may not have the health workers. It may not have other things, and yet people have actually paid for the insurance. Those are gaps that we hope that we can close. And we are looking, and we are very happy to have partners sometimes like Kizor, who actually help us equip those facilities, maintain the equipment, like you heard, with a stable supply of electricity. Biomedical equipment is very expensive. If you've been to Africa, you know that most of our facilities are graveyards of biomedical equipment that was procured at great cost by government and, of course, the partners. Sometimes what blows up is simple things because of the fluctuating power supply. So that investment for us is a game changer, and if we can have that, then we can ensure that all the facilities not only have equipment that is safe to provide safe surgery to the people, but also it cuts down on a lot of costs. So creating those delivery mechanisms, ensuring that we can actually implement the policies we are developing on the ground is key. Because like I said, that's the framework. If we cannot demonstrate that impact of what you're investing in or what we're investing in, then again, it's an effort in futility. But then we also there are also other opportunities that we have on the ground to unlock further funds that can come into the insurance. For example, the social health insurance in Zambia does not cover accidents. We have a lot of road traffic accidents. We have a lot of industrial accidents. We do have accidents even at the homestead. Now, that component is usually not covered, and the private insurances also don't cover it. But we have been brainstorming, and we've realized, for example, that motor vehicle insurance does cover the patients that come from this trauma, especially for the road traffic accidents. Every vehicle driving on the Zambian road is insured. And the primary target and recipient should be the victims that survive from that road traffic accident. But we haven't created mechanisms to follow up when an accident happens. Patients are brought to me at a university teaching hospital, and I'm struggling. I don't have sutures, I don't have bandages, I don't have this to use. And yet these patients were already covered in that vehicle. So what we lack is the mechanism to try and follow up to ensure that those insurance companies that insure those vehicles can provide the care upfront. What we have seen usually is that nobody follows up these issues, and then we mismanage the patient because we are lacking resources. And at the end, as you know, they end up physically disabled. In our environment, you cannot survive very well if you're physically disabled. And surgical disease is physically debilitating. We need our hands and our legs to earn a living. And so compensation that we have to now compensate people based on schedules that were made in 1972 is not appropriate. We want the money from insurance companies to come up front, so we can have all the supplies and equipment and resources, so we can treat these people, so they can get back to work and grow the economy that we are trying to do. So So those are the areas that we see specifically for Zambia that could be helpful. We expand the social health insurance. We ensure that we can put in the delivery mechanism to actually ensure that those who are covered can receive care, because like I said, you can have the insurance, but if we don't have the machines and everything to actually provide the care, then you're paying, but you're not getting the service. That's not okay. And then we are also innovative. We want to unlock other areas that can bring money, that can cover the trauma, because the trauma component is very big. And we're losing the most productive age group in our population. We're in a hurry to get developed. We need our people to be healthy to develop.